the next speaker. The next speaker is my good friend, Dr. Bancha. Dr. Bancha is an associate professor at the Department of Orthopedics, Faculty of Medicine, Thammasat University of Thailand. He's a very experienced shoulder surgeon, and his talk is very lovely. You will enjoy it just like me. So Bancha will talk about shoulder instability in the elderly in the subsequent 25 minutes. Bancha, I hand the time to you.
Thank you. Good afternoon. I'm Dr.BanchaChernchujit from Thammasat University, Thailand. Thanks the organizing committee, Class Connect, for the invitations. And nice to see old friends, Dr. Ng from Malaysia and Professor Peter from Hong Kong. And also thanks for my 6 fellow from this preparation of the talk. For the shoulder dislocation in elderly, why is this important to talk about the shoulder instability in elderly? The answer is because the shoulders in the young and the elderly are not the same. In elderly, the mechanism, pathology, and line of management are totally different from the young. So dislocation in elderly may associated with cuff tear, large bone defect because of the osteoporotic bone. GT fracture is more common in elderly. Nerve injury also common in elderly, which are totally different from the young. The incidence of dislocation is bimodal distribution. It's common in the young, skip the middle age, and common again in elderly. Now, our lifespan get longer. We as a surgeon will see more cases of shoulder instability in elderly. So it is important to be clear how to manage this patient. The recurrent rate and pathology of the dislocation is different. 25% in elderly and 90% in the young. The cuff tear is more common in elderly. The incidence is about 60%. In contrast, the capsule label tear is common in the young, 70 to 100%, but cuff tear is only 15 to 20%. So these are the difference. This is a terrible triad which is more common in older patients, composed of shoulder dislocation, rotator cuff tear, and nerve injury. This is not common in the young also. The prognosis of this triad is depending on the nerve recovery, and most of the time it's recover. And the second is how good you can manage the rotator cuff. Don't miss it. The shoulder instability composed of static and dynamic stabilizer. In the young, the static stabilizer, capsule label complex, is more important than the cuff. So this we call the entry mechanism. But in older patients, the dynamic stabilizer play a bigger role. So this is a posterior mechanism, is a head depressor. If the rotator cuff muscle strength reducing by half, it will be increase the displacement by 50%. This show how important the dynamic stabilizers are to keep the glenohumeral joint stable. About the mechanism of injury. So in elderly, it's always low energy trauma, which is different from the young, which have high energy trauma like sports injury or traffic accident. So this less common in the elderly. Most of the time it is very low energy trauma. So it can be entry dislocation, posterior dislocation, or infra dislocation. So the technique of reduction is also different from the young for the elderly, because I don't recommend you to do the leverage technique in elderly because of the soft bone. Sometimes the patient have the heel sac lesion, big heel sac lesion, you may create a fracture. So this is a modified traction, counter traction for the antero-inferior dislocation. It's safe, easy, and reproducible. It was published in 2014. So this is my patients. I do the traction, counter traction, modify, because she has a very big heel sac, and this patient had 3 weeks of dislocation. Try not to do the leverage technique. You can create a fracture or fracture dislocation. I saw this fracture dislocation more than 5 patients. So very careful when you try to reduce this dislocation in elderly. So this is the way you should not do in elderly. Try not to do the leverage technique in elderly because sometimes you can create a fracture or fracture dislocation because of osteoporotic bone, or sometimes the patient have non-displaced neck fracture, like this example. See that? This patient have the GT fracture, but after the reduction, it is a fracture dislocation. Okay, so we need to do the reverse shoulder arthroplasty instead of conservative treatment. So post-reduction X-ray is important. You need to look for the tuberosity fracture. You need to look for the size of chronic rotator cuff tear, because some patients have impending cuff tear, existing cuff tear. Look for the acromion spur. Okay, need to look for the suture size, looking for the humeral head migrations. So if you see these X-ray findings, thinking about the patient may have pre-existing cuff disease or impending cuff tear. When we do the CT scan, when should we do that? If there's no noise fracture, suspect the head split fracture to calculate the amount of bone loss, or in some patients that have persistent dislocation, we want to see the degree of bone defects. So the CT scan will be useful. So MRI, we do that, and the patient had persistent pain and weakness after the dislocation, because simple labral tear, the shoulder pain should be better within 3 weeks, or especially the patient who had first-time dislocation at the age more than 40 years. You should consider the MRI in these kind of patients. It's important. We do conservative treatment in the patient who had first-time dislocation, no displaced GT fracture after the dislocation, no traumatic cuff tear, and good shoulder stability. So this is an example of one patient has a fracture dislocation of GT. So after the reduction, I put her in the abduction brace, okay, and conserve. So I think it's important to put the patient in abduction, external rotation, and exercise the deltoid. Otherwise, the fracture will be displaced posterior superior. So that's why we need to put the patient in abduction, external rotation. And this is the result. I saw many young surgeons do a lot of GT surgery because they treat it conservatively in the wrong way. Okay, so you do it the right way, the patient will have good result like this. Okay, this is 4 months after the conservative treatment. So weakness after the reduction, why? You should think about because of cuff tear or not. The patient would have painful pseudoparalysis, or because of the nerve injury, axillary nerve or brachial plexus injury, that may have painless pseudoparalysis. Like the first patient have the massive cuff tear, the second patient have the axillary nerve palsy, and the third patient is a brachial plexus injury. So this is the incidence of nerve injury in shoulder dislocation. Axillary nerve is most common, 86%, suprascapular nerve 30%, and musculocutaneous nerve about 24%. So this nerve complication is about 5 to 55% in all dislocation. Even low energy trauma can create the brachial plexus injury in elderly. 13 to 80% require surgery if there's no sign of recovery within 3 to 6 months. The most common tear pattern is a posterior superior tear. The patient would have the weakness of supraspinatus, infraspinatus, and sometimes the teres minor. So this is an anterior tear. The patient may have belly up sign, Napoleon sign, lift up test positive, internal rotation lag side positive, or back hug test positive. That is worse prognosis in this kind of patients, but it's less common than posterior superior cuff tear. So like this patient, we need to evaluate the pseudoparalysis and find the root cause of it. It is because of nerve problem, or is it because of tendon problem? This is a bad sign. If you have fixed proximal migration, soft tissue procedures may not able to solve this problem. This may end up with the reverse shoulder arthroplasty. Muscle atrophy is a bad sign of the disuse atrophy, or it may be from the nerve injury. So the patient may get longer recovery if the patient have the muscle atrophy. So this is the treatment algorithm. You should looking for the pathology. Is it just the capsulolabral tear, or is it the capsulolabral tear together with the cuff tear? Is it repairable cuff or repairable labrum or not? Is there any arthritic change or bone loss? Is there any severe lock dislocation? So in this situation, you may end up with latarjet or may end up with the shoulder arthroplasty. So this is my preferred position. We call this TU supine position. It's very simple. And you look in these pictures, the patient just used the local nerve block, right? He can go back home right away because no intubation. Very comfortable position. Just let the patient sleep and local nerve block. So this is my articles about this TU supine position for this shoulder arthroscopy. It's very convenient. Okay. So I use 3 portal for the surgery. I start with my posterolateral portal. It's about posterolateral. It's not the lutein posterior portal. So this portal you can see better and also you can work better, right? You can put the anchors at 6 o'clock and also you can do the posterior label repair at the same time. So I put my anterosuperior portal just underneath the bicep, just above the bicep in front of the AC joint. My anteroinferior portal just above the subscapularis between the MGHL and SGHL. Okay. And these 2 portals should be not too close. The angle between these 2 portals should be about 70 degrees. You should not too close, otherwise you get portal jam. And we start the capsule label repair using the Y knot. We start at 6 o'clock position after complete the label detachment. And after that, if the patient have cuff tear, so we can continue to do the cuff repair using the same position. You don't need to change. So this is like one example. So most of the patient need to be repaired because this is traumatic cuff tear. You have no role of conservative treatment in traumatic cuff tear. Okay, and also persistent loss of function. So I show you the Y knot. Yes, I prefer the triple load Y knot. We call this the 3-in-1 techniques. 3-in-1 hole. It's very fast, very easy. Okay, so you can put suture hook the spectrum and you pass 3 sutures into 1 hole. So you have less problem about the tissue strangulation, less tissue trauma, and this is faster. Okay, so after that you tie the knot, but you just tie 1 knot in the front, 1 knot in the back, 1 knot in the middle. Okay, and then that's it. And then you can do the double row, the second row repair. Okay, so that's very simple, straightforward, right? For this the cup repair, the 3-in-1 holes technique. Okay, that is a medial row, and after that you retrieve the sutures to the lateral row, and then we use a pop lock for the lateral row repair, right? I prefer to put my lateral row very far away, one close to the bicipital groove because of the good bone quality, and also another one close to the posterior cortex. Okay, so you can have the very wide area of suture distribution. Yeah, that is the 3-in-1 holes. Yeah, it takes you for the repair only half an hour. Okay, but we spend a lot of time for the tissue mobilization, for the bursectomy, but for the repair it takes very short time. Okay, and you have less soft tissue strangulation using this technique. Okay, I use Y knot at the middle row and pop lock at the lateral row. So you need to think about what is your main problem. Okay, if the patient have small size cuff tear, the main problem is the labrum, it's not the cuff. So if the patient have medium size cuff tear, thinking about both problem, the labrum and also the cuff. Okay, you need to fix both. For the massive cuff tear, so your main problem is mainly the cuff. Okay, it's not the labrum. Most of the time, sometimes you didn't see any cuff, any labral tear in the massive rotator cuff tear with dislocation. So this is a very simple clue. Okay, small size, thinking about the labrum. Medium size, think about both. If you have large size cuff tear, the rotator cuff is the main problem. So this lady, she's 70 years old. First time dislocation, she showed me. She just stand up from the toilet and the shoulder dislocation. So I'm very surprised. She's 70, but she have good rotator cuff, you see. Supraspinatus, subscap is good, but she has heel sac lesion, engaged heel sac lesion, but there's no glenoid bone loss, okay? So this is very weird for me. So this patient, I perform the arthroscopic examination. We see that the patient have the big heel sac. So we put the Y knot into the heel sac. I put 2 Y knot into the heel sac. I think Y knot is very good for osteoporotic bone because you can put it into the subchondral bone also. It's very small. Don't need to make a pilot hole. So after I pass my suture into the infraspinatus posterior capsule, then I address my anterior label, put the Y knot there, okay, and then repair. So we're starting repair from posterior portal to eliminate the axillary pouch, and I always use the double load anchors. Okay, for me, I think the Y knot is pretty good for the osteoporotic bone. I never have problem with my Y knot. Okay, so after that you do the limb massage. Okay, so we discuss with Peter again. Why don't you love limb massage? I love limb massage so much. Okay, Peter, you need to answer me why you don't love limb massage. So this is a 50 years old male. He has first time dislocation from minor traffic accident. So he has so much pain and cannot move. The nerve is good, right? But he cannot move. He came to see me about 6 weeks after the injury. The patient gets stiff shoulder. He had the tuberosity fracture, you see, GT. But luckily, 6 weeks, the GT already healed. And you look at the glenoid, you see that the patient have broken glenoid. At this right picture, you see that the glenoid pieces is so big. So his problem is the glenoid defect. I discussed with him that I will fix his glenoid. Yeah, so we get in and detach everything. The glenoid defect is about 30%. It's so big. So we use the spectrum to repair the posterior labrum first. Okay, and then using the soft anchors. Okay, you see that we can repair this bone. I prefer to do this way using the soft anchor. Yeah, and then you can reduce this big piece of bone. You see that it's very big. But don't worry, I don't like double row because it's too complicated. I use this single row, make a big bite. Don't worry that it will overhang because the head will mold this fragment to flat. I never have the problem with this overhanging because after you release the traction, the head will mold this fragment nicely. Okay, so this is after the repair, and the patient getting much better, and the healing is perfect after 3 months. Yeah, he also have the labral tear in the back, so we also repair his posterior labral lesions. This patient, she had dislocation, but she has the medium-sized cup tear. So when you see the medium-sized cup tear, thinking about labral tear also, right? Like I show you in the algorithm. So she has a 4-time dislocation. From the MRI, we can see that the patient have a medium-sized cup tear. There's a heel sac lesion also. When we get in, we found that the patient have labral tear, right? So in this situation, you need to address both the labral pathology and cuff pathology. Okay, so I always repair from the back, repair the labrum. So after I finish my labrum, I go to the subcumen space, okay, and then we do the labral repair. Sorry, the cuff repair. So also use the 3-in-1 hose technique. Yeah, it's very simple, easy, and very fast. So the patient doing well after the surgery. So this is the post-op about the 4 months after surgery. The patient doing well and had the full range of motion. She's very happy. So this is a medium-sized cup tear. So in other patients, this is also common in elderly, the GT fracture, right? This patient have 2 months history of GT fracture. So after the conservative treatment is failed because the fracture displaced more and persistent instability. So this is the inter-op findings. Yeah, when we get in, we found that the patient have good labrum. For this patient, the labrum is intact. Okay, so we do the release. Okay, put the Y knot at medial row. Okay, and after that we tie the medial row and doing the tuberosity fixations. Okay, for the small size tuberosity, it's good to use the arthroscopic treatment. For the big size, I do open, but for the smaller size, I prefer to do this arthroscopic fixation. So you see the GT heal nicely 1 year after the surgery, and the patient had pretty good results after the surgery. So the next patient is at Thailand. So he has accident during the games. So this patient have posted dislocation, right? And also there's a fracture of the scapula and also distal clavicle, very complicated. So I get in, I fix the bone first. I fix the AC joint and fix the scapula of the patients. And then we get in to do the arthroscopic posterior capsular label repair. Okay. So this is the label repair. The patient have torn labrum and also extending to the biceps. So that is after the label repair. Yeah, here's some bony fracture also, right? After the fixations, this is about 1 year post-op. The patient have pretty good motions. So I removed the hook plate already. It's healed nicely. And the patient motion is pretty good. So now he can go back to the games again, right? And here's some nerve injury also at the beginning, but the nerve come back after the surgery. He also have the suprascapular nerve trauma because the fracture extend very close to the nerve, and maybe it's because of me. When I put the plate in, I do some traction to the nerve. Okay, but anyway, all the nerve come back. 60 years old, neglected dislocation from traffic accident. So we have a lot of traffic accident in Thailand, you see. Even he's the 60 years old, so if you ride a motorcycle and there's some traffic accident, it was missed because this is a posterior dislocation. So I discussed with the patient that I will try to do arthroscopic release first. Okay, we get in the joint and try to release the rotator interval and slowly external rotate, and finally we can reduce the head back. Then we do the McLaughlin procedure, put the suture anchor at the defect and repair the subscap back. So after repair the subscap back, the head was reduced to the center and performing the posterior label repair, right? So this is a films after the surgery, and the patient getting much better. This is a few weeks after the surgery. Now the patient not coming back to see me. So in Thailand, if the patient not come back to see you, that means he's good. Yeah, because if he's not good, he will come back to see you, right? Yes. Another patient, he's 58 years old. He's a doctor, dermatologist. So it was missed again, the posterior dislocation. Oh, it's long time, so the cartilage was gone. Yeah. So I discussed with him, I need to do joint replacement for him. Another 52 years old, I just do that last month. Actually, I sent this into the group. Peter, you saw that? These
Yes.
patients, right? 52 years
Right.
old, lock dislocation after the seizure, okay? So now the seizure can be controlled. So the defect is so big, you see from the MRI, right? From the CT scan, it's so big, but the glenoid defect is not too bad. So when I get in, I found that the patient have very big Hill-Sachs lesion, but there's no capsule. So this patient, we need to decide to do the Latarche procedure because he has no capsule. And also we need to fill the defect with the allograft, okay, and do the Latarche. And then we do the fixation of the lesser tuberosity back. I prefer to do lesser tuberosity osteotomy to get the biceps tenodesis. So the shoulder getting stable, okay? And the patient now is getting better after the surgery. And this is the films after surgery. Yeah, it look nice. So another patient, 76 years old. We have a lot of elderly dislocation and different scenario. This one, minor fall and misdiagnosed 3 months. So the patient came to see me. I say she's 67, no, 76. So reverse should be the solution for her, okay, because she have torn everything, rotator cuff, okay. But this patient also have nerve injury at the beginning. I discussed with the patient that I will try this because even you have nerve injury, the nerve always come back, right? So luckily the nerve come back, right? He's happy after surgery and have good motions and function after the surgery. But this patient, 73 years old, same neglected dislocation, same scenario. Yeah, but this is about 6 months after the injury. So I discussed with him that I will try to do the same way. Okay, you have the fracture dislocation, but you also have nerve injury. So after the surgery, the patient doing well, but he come back to see me with this. You see that the muscle atrophic change and the nerve is not coming back. So this patient had the dislocation again because of the bad nerve. So I revised that again, put a bigger spacer, and he come back again and again. And finally, this patient got the heterotopic ossification. Yeah, so now he's not come back to see me because he's good, but he cannot live up, but the shoulder is stable now. You can see that there's some heterotopic ossifications. So take home message for this elderly dislocation. Shoulder dislocation in elderly is not the same like in the young. The soft tissue dynamic stabilizer are more important, and the rotator cuff is commonly torn and must be repaired. Even in the emergency department, the reduction must be done carefully to avoid the fracture during the reduction. Often combined label, capsular, and cuff repair is need to have a good motion and function. If it cannot be repaired, that is the option of the replacement. Thank you.